You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for October 13th, 2023. This week, we'll do 3 stories on the ups and downs of GLP-1 agonist, imaging during procedures, and the amazing power of sham controls. First order of business is to thank the European Association of Cardiothoracic Surgery for inviting me to speak at their recent meeting. This was a great meeting. This organization impresses me because of their commitment to evidence appraisal. I got acquainted with EX through the late Domenico Pagano, who I think of every time I go to an EX meeting. Gosh, he was really great. I miss him. First topic today is semaglutide. The GLP-1 agonist was in the news again. Can you believe it? This week, via a press release from Novo Nordisk, a company whose valuation is exceeding many Western countries, announced that the kidney prevention FLOW trial was stopped at an interim analysis. The FLOW trial is the effect of semaglutide 1 milligram versus placebo on the progression of renal impairment in patients with type 2 diabetes and CKD, chronic kidney disease. Why was the trial stopped? For efficacy. That is why. FLOW enrolled more than 3,500 patients in 28 countries. It had a complicated composite endpoint, and it was the onset of persistent greater than 50% reduction of the eGFR, the onset of a persistent eGFR less than 15 milliliters per minute of 1.73 meters squared, start of dialysis or kidney transplant, death from kidney disease, or cardiovascular death. So a 5-component, very complicated composite endpoint. There were also key secondary endpoints of the FLOW trial, including cardiovascular endpoints like MI, stroke, and cardiovascular death. This is a big deal. RCTs have shown substantial weight loss in patients with obesity with semaglutide. We've learned now that the SELECT trial, which is positive, going to be announced at AHA. This is a cardiovascular outcomes trial in patients with obesity, so that's really important. And now we have kidney prevention. I mean, think about it. Weight loss, that is more than surgery. Cardiovascular outcomes trial is going to be positive. Renal prevention. It's really amazing drug class, perhaps a truly new category of cardiovascular prevention. There was other news on semaglutide this week as well. This was the STEP-HFpEF trial. But it really wasn't that big a news. At the Heart Failure Society of America meeting, HFSA, investigators from the STEP-HFpEF trial published a substudy that was, wait for it, positive. Yes, positive. I say this wasn't news because if a trial is desperately flawed and mostly a marketing exercise, a substudy of said trial by the transitive function also has to be flawed. Now, I've covered STEP-HFpEF during the ESC meeting in late August. The title of my column, written column, was, quote, semaglutide and HFpEF cleared a low bar. That's because STEP-HFpEF was an RCT of patients with HFpEF and obesity. The primary endpoint, though, was a subjective quality of life endpoint and weight loss. They randomized only a few hundred patients. Patients on the drug lost weight, of course they did, and then they were surely not blinded anymore because they lost this weight, and they reported better quality of life. This was a lead study at ESC. It was published in the New England Journal, but I believe it was mostly marketing. Now, at the heart failure meeting, we get a substudy looking at the effect of semaglutide on the primary endpoint based on 3 categories of ejection fraction. I kid you not. Ejection fractions 45 to 49, 50 to 59, and greater than 60. And of course, the drug resulted in better scores on the KCCQ and similar weight loss regardless of the EF. My gosh, this class of drugs is clearly going to be beneficial, no question. But this STEP-HFpEF and any subsequent studies are really dubious. I mean, regarding this study, the first thing to say is separating these EFs like that really belies basic understanding of measuring heart function, right? The difference between an EF of 49% and 54% could easily turn on whether the sonographer was hungry or aggravated or distracted. You can tell the difference between an ejection fraction of 35% and 50%, but these categories are nutty. And the fact that they put this off as serious really strains credibility, I think. Worse, the ejection fraction was not even measured in a central lab. This was published in JACC, one of our strongest journals. Trial discussant, the very smart Professor John McMurray from Glasgow, asked whether the weight loss was the sole effect responsible for patients feeling better. I was not there, but I am sure that Professor McMurray asked the question very nicely. It is his way, but of course it was the sole effect. If you have a stiff, non-compliant heart and you're deconditioned and you are obese, and you take something that causes that much weight loss, of course you will fill out the KCCQ questionnaire more favorably. GLP-1 agonists are likely to be useful drugs in this cardiorenal space, but STEP-HFpEF will remain one of the best examples of marketing disguised as science. Bookmark the study. Tell me I'm wrong about it. Okay, final GLP-1 agonist topic is a little bit of headwinds. One more study on GLP-1 agonists to discuss this week. This one is in JAMA, and it's about the downsides. This was from a Canadian group, first author, Mohit Sodhi from the University of British Columbia. The study question was the incidence of GI adverse effects. They point out in their short introduction, this was a research letter, that the RCTs were not designed to capture adverse effects. That is actually a common issue with RCTs, right? Trials are mostly designed for efficacy. So the four authors use a different methodology to get at these adverse effects. They took a random sample of 16 million patients from a health claims database. They included in this cohort study both semaglutide and liraglutide. The active comparator was bupropion naltrexone. The brand name is Contrae. This is a weight loss agent unrelated to GLP-1 agonist. And patients were observed from the first prescription of a study drug to the first mutually exclusive incidence of biliary disease, which included cholecystitis, cholelithiasis, choledocholithiasis, pancreatitis, bowel obstruction, or gastroparesis. Now, before I tell you the results, we should say that this is a retrospective, observational, and non-random comparison. Because clinicians, not randomization, chose the drug, the authors did do a bunch of statistical adjustments and they published sensitivity analysis. They had about 4,000 patients on liraglutide, 600 on semaglutide, and 650 on bupropion naltrexone. The main finding, use of GLP-1 agonists compared with bupropion naltrexone was associated with a 9x increased risk of pancreatitis. The adjusted hazard ratio was 9.09. A 4x increased risk of bowel obstruction, hazard ratio of 4.22. And a 3x increased risk of gastroparesis, hazard ratio of 3.67. But there was no increased hazard of biliary disease. Exclusion of hyperlipidemia from the analysis did not change the results. The inclusion of GLP-1 agonists, regardless of the history of obesity, reduced the hazard ratios and narrowed the confidence intervals, but did not change the significance of the results. They also did sensitivity analysis, and these did not suggest confounding by BMI. Now, first thing to say about this is these are relative risks, right? The crude risks are in the range of 1 per 100 patient years. That's low, but it's not that low. The point is that these drugs are not free. I've never had pancreatitis, but I don't think it is pleasant, nor is bowel obstruction. The adverse effect issue brings up a core tenet of medicine, of medical practice. That is, we always risk stratify treatment. If you are treating a patient with obesity who has CKD and diabetes and/or heart disease, the benefits are surely going to outweigh the harms on average. If you're treating for softer indications, say just obesity without much comorbidity and without a good trial of old-fashioned reduction of eating Cheetos, then a serious episode of pancreatitis is a huge negative. Well, nothing in medicine, surely nothing you inject, comes free with all positives. I say good on the authors and JAMA for publishing this important study. All right, next topic is imaging during PCI. The European Heart Journal has published an observational study of U.S. Medicare beneficiaries from 2013 to 2019. First author, Reza Fazel. The objective was to describe the trends and outcomes of using imaging to assist PCI, percutaneous coronary intervention, or stent placement. Here is a brief background. When a coronary lesion is treated, the doctor usually places a stent, and in days of old, the guide was the angiogram and skill and experience of the doctor putting the stent in. However, now we can see things. Intravascular imaging, say ultrasound, allows a doctor to see the stent in the vessel. Is it well opposed? Is it positioned properly? Is there stent edge dissection? Imaging can also help before stent deployment to better determine things like plaque burden, calcification, etc. Okay, now I'm sure you're asking, is there data? I mean, imaging sounds great, but what do the trials say? Indeed, there are trials, many of them, actually. There are also meta-analyses of trials, many of them too. They document universally better outcomes from PCI when it is used with imaging, less death, less MI, and less target lesion revascularization. Both American and European guidelines give 2A recommendations to imaging use during complex PCI. The U.S. authors of the recent European Heart Journal paper write that most of these trials were done outside the U.S. and are, quote, rarely representative of the broader population of patients treated, end quote. I'm not sure why, but they say that. Their study population included nearly 2 million patients having PCI. 2/3 of these were during MI. Overall, imaging was used in 10% of cases, increasing from 9.5% in 2013 to 15.4% in 2019. The translation of that is that the most recent data is that about 85% of PCI is done in Medicare beneficiaries without imaging. The study also found that imaging use associated with lower rates of mortality, adjusted hazard ratio 0.96, MI, adjusted hazard 0.97, and repeat PCI, adjusted hazard 0.74. The authors are pretty expert in observational studies and did a falsification endpoints to check for confounding for healthier patients, and they found no association with pneumonia or hip fracture, and they concluded, quote, among Medicare beneficiaries undergoing PCI, use of imaging has increased over the previous decade but remains relatively infrequent. They also concluded that imaging-guided PCI was associated with lower risk-adjusted mortality, acute MI, repeat PCI, and MACE. They did make some comments in the discussion. They said that our study adds to the growing body of evidence indicating that intravascular imaging use improves outcomes for patients who have PCI, and, quote, understanding the reasons for my emphasis, underutilization of imaging in the USA, despite existing guidelines and evidence, is essential to increasing its use in appropriate cases. They also tell us, and I didn't know this, that there are 3 ongoing trials looking at imaging for PCI. And that's somewhat curious because a review article that I found in the journal Heart, and I'll link to it, first author Mintz, M-I-N-T-Z, found at least 20 RCTs in the published literature already. My comments. As you all know, I don't do PCI, but I find this a very interesting topic. There is strong data suggesting benefits. But the procedure costs extra. It takes a little extra time. It requires humans to accept that the old way may not be adequate. U.S. data shows uptake is very low, and this U.S. observational analysis comports with the RCTs, which show benefit. I'm wondering why. Why, if this improves outcomes, why is it not a Class 1 recommendation? And why is it not more accepted? Looking in from the outside, it looks like American doctors are a bit impervious to evidence. And one quick contrast with my field of ablation for arrhythmias, imaging via intracardiac echo, or ICE, is quite common during AF ablation in American centers, but is quite uncommon in many European centers. Well, cost has been one of the large reasons for the difference, but I know of no proper RCTs comparing ablation with and without imaging. I've been skeptical that intracardiac echo adds much. I did ablation for a decade in the European way, but have switched to the American way in the last decade, and I don't really see much difference. So at least the interventional community has tons of data supporting the use of imaging. The issue seems mostly about uptake. I read in the editorial of this paper that uptake of intracoronary physiology has amazing uptake, like FFR. But FFR has absolutely terrible evidentiary support. Consider that FAME-2, one of the seminal studies which established FFR, was positive only because of urgent revascularization, and that trial was unblinded. I'm happy to have any feedback here. Why would interventional cardiology not embrace a technique with clear evidentiary support? Let me know. Okay, next topic today is about the importance of sham controls. Regular listeners know that I feel strongly that procedure trials should have proper placebo controls. Sometimes these are called sham controls. I don't love that term because without a proper placebo control, sometimes the trials are actually shams. A study presented at the heart failure meeting provides a shining light on why sham controls are vital to knowing what works. Journalist Steve Stiles covered the story. The trial is called REBALANCE-HF. The procedure studied was ablation of the right greater splanchnic nerve. The idea is to improve fluid balance in patients with HFpEF. I know. I too have never heard of this before. Here is the brief summary of things that I found out. Now, we know the problem in HFpEF is elevated left-sided filling pressures. This happens for reasons both cardiac and non-cardiac. In HFpEF, one may get a functional shift of blood volume between the unstressed vascular compartments and consequent physical shift of blood from the peripheral circulation, which is predominantly residing in the splanchnic vascular bed, a shift to the central vascular compartment, and that results in congestion and increases of central and pulmonary venous pressures. The splanchnic nerves are part of the sympathetic nervous system. In HFpEF, there is overactivity of sympathetic nervous system, and this may cause less volume in the splanchnic beds and more in the central circulation. Therefore, by ablating the right greater splanchnic nerve, you may get dilation of the splanchnic blood pool and reduction of the transfer of fluid to the central circulation. Preclinical studies actually have shown that GSN block reduces exercise pulmonary capillary wedge pressure, and a single-arm study published in JACC-HF last year found that right-sided GSN was safe and improved subjective clinical metrics, and I'll link to that paper. Now, GSN is done by placing a small ablation catheter down the azygous vein into the right GSN branch. It doesn't sound all that easy, right? Femoral vein, then azygous vein, then the 10th to 11th intercostal vein. REBALANCE-HF, however, was a much harder test than any single-arm study. Right GSN versus sham GSN. The primary outcome was a change in pulmonary capillary wedge pressure at 1 month. Safety outcome was procedure-related adverse effects, and the procedure ended up being pretty safe. The trial is not yet published, it's just presented, but the results were negative. No difference in the primary endpoint. They also performed similarly on quality of life questions from the KCCQ. Now, there was a talk at the meeting about a secondary analysis wherein a subgroup of patients did better, but as you know, that is problematic because the trial was quite small to begin with. Now, maybe this subgroup will form the ability to do a second trial in these specific patients, but we'll see. My comments here, please read Steve's report. It is excellent. But a point of covering this is that it shows the power of sham controls, not only on subjective endpoints, but also objective endpoints such as the pulmonary capillary wedge pressure. I will remind you that the recent Triluminate trial of edge-to-edge repair of the tricuspid valve is celebrated as positive. It seems to be accelerating the field of clipping the tricuspid valve, and it had no sham control. There is a way to do science in the field of interventional cardiology. It includes sham procedures. At AHA next month, I look forward to learning the results of the sham-controlled Orbita 2 trial. And gosh, would I love to know the placebo-resistant effect of AF ablation, and there actually are some sham-controlled trials ongoing in that space. So that's it for this week in cardiology, but I want to say one thing before I close. This is Steve Stiles' last month at the Heart.org Medscape Cardiology. Steve is retiring. He deserves to retire. He's been doing this a long time. He is one of the best journalists I have ever met. He has taught me a ton over the last decade. I really appreciate all of the guidance and teaching that he's given me. He's been excellent, and we will miss him. So, Steve, congratulations on your retirement. Okay, that's really it for this week in cardiology. And remember, if you like this podcast, please take the time to give us a rating, write us a brief review. We're almost up to 700 ratings on Apple Podcasts, so thank you for that. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.